Bismillah ar-Rahman ar-Rahim. In today's session, we are going to discuss the role of fibers in a functional constipation, the evidence-based approach for clinical practice. I am Professor Dr. Javed Iqbal FAROOQI, and you are watching my YouTube channel, Medicine Made Easy. The target audience for today's sessions is gastroenterologists, general physicians, and internal medicine doctors. The learning objectives of today's sessions are that by the end of the workshop, we will be able to understand the pathophysiology of functional constipation, explain the types of dietary fibers and their mechanism in relieving constipation, to identify appropriate fiber-based interventions for different patient populations, and apply evidence-based recommendations in clinical practice. And last but not the least, to counsel patients effectively on diet and lifestyle modifications. So these are the objectives of today's session. Let's start from the definition of functional constipation. We all know the definition comes from the Rome 4 criteria, and we must recall are the Bristol stool chart: type 1, type 2, type 3, type 4, type 5, type 6, type 7. And the 1 and 2 are the features of the constipation. The functional constipation, we know it's according to the Rome 4 criteria, the criteria is fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis. So this is the basics, that the criteria should be fulfilled for the last 3 months with symptom onset at least 6 months prior to the diagnosis. So there should be 6 months duration that the symptoms started. And the criteria must include 2 or more of the following. What are these? Fewer than 3 bowel movements per week, or straining during more than quarter time of defecations, lumpy or hard stools, that is the Bristol stool form scale 1 and 2, more than 25% of defecations, and sensation of incomplete evacuation more than 25% of defecations, sensations of anorectal obstruction or blockage more than quarter time of defecations, and at times manual maneuvers to facilitate more than 25% of defecations, that is digital evacuation, support of the pelvic floor. So if someone has got 2 or more of these 6 features, then we say the patient has got functional constipation. The epidemiology and prevalence, it's the global problem. No country is spared. It affects both male and females and all ages, even the pediatric age, the adult, the young age, and the elderly age. And around 20% of the population, they have suffered from constipation at some time of their life. The clinical features, as said before, there is abdominal pain and bloating, then pushing and straining more than usual, small hard bowel movements, and bowel feel blocked, and at times use fingers to assist, and less than 3 bowel movements without laxatives per week. All these are the different clinical features, and a person may have one or two or more than these features to qualify that the person is having functional constipation. What is the causes? What's the underlying pathophysiology of functional constipation? The first important one is the slow colonic transit. The peristaltic waves, they are sluggish, they are slow, or at times they may be absent. So the first pathophysiological factor is the slow colonic transit. Then is the pelvic floor dysfunction. This is the second important pathological factors which leads to the onset or development of the functional constipation. And of course, altered gut microbiota, the dysbiosis. This is also a contributing factor in the development of functional constipation. Types of dietary fibers. What are the types? One is the soluble fibers, which form gel. They absorb slowly and they are fermentable like oats and isfahol. Then there are insoluble fibers. They add bulk to the stools. They speed transit like wheat, bran. These are the insoluble fibers. Then there are fibers which make viscous or non-viscous, and then there are fibers which are fermentable or non-fermentable. The mechanism of fibers in constipation. How do they help? They improve colonic transit and the time of the stools from the uh, proximal part of the colon to the distal part, it is shortened. Then they increase stool bulk. This is again very important. And then they enhance water retention and thus they improve the transit of the stool matter, fecal matter across the colon. And it modulates gut microbiota, that is the prebiotic effects. So all these are the different mechanisms with the help of which fibers help in constipation. They improve colonic transit, they increase stool bulk, they enhance water retention within the lumen, and they modulate gut microbiota through their prebiotic effect. What is the evidence? What the evidence says? The evidence says, the meta-analysis says that Swahol husk versus wheat, bran versus inulin, and they say that the Swahol husk, they are better than the wheat and better than the inulin. This is. And efficacy, they help the stool frequency is improved, the consistency is softened, and there is symptomatic relief. The recommended dosage is 10 to 30 gram depending on fiber type. So with this background, let's go through few case histories and see how we can use the fibers in different case scenarios. The first case history is a 68 years old man with chief complaints of difficulty passing stools for the last 6 months. Stool frequency is 2 to 3 times per week and the stool is hard and lumpy. Medical history, he is hypertensive and type 2 diabetes. And the medications he is using amlodipine and metformin. Diet history suggests or shows that he diet is low in fruits, vegetables, and whole grains. And physical activity is limited mobility due to knee osteoarthritis. On examination, vital signs normal, no palpable mass in the abdomen, and digital rectal examination, hard stools in rectum. So the first question of this patient is, what type of fibers would be most appropriate for the patient? So, in your opinion, what type of fibers would be most appropriate for the patient? You may write down the answers on the paper or just make a statement in your heart. And let's see what the answer is. Soluble fibers is preferred as it softens stool and is generally well tolerated. The second question, and there should be moderate use of insoluble fibers, wheat bran, and it can be added if tolerated. So the second question is, what dosage and form, supplement versus dietary, would you recommend? Just think on the answer. And let's see what the answer is. Xylem 5 to 10 gram once or twice daily with adequate water. And encourage dietary sources, that is the oats, fruits like apples, pears, and vegetables. The third question to you is, how would you counsel him to gradually increase fiber intake? Just answer in your heart, make your mind, and let's see what the answer is. Gradual fiber increase over 1 to 2 weeks to avoid bloating or gas. And ensure daily fluid intake of 1.5 to 2 liters. Encourage gentle physical activity as tolerated, that is walking. The fourth question is, are there any contraindications or precautions considering his comorbidities? He's diabetic, he's hypertensive, and osteoarthritis. So the answer is, monitor for bloating, gas, or medication interactions. Start low, go slow. Avoid sudden high fiber intake. The fifth question is, would you suggest combining fiber with other interventions, that is hydration, physical activity, and laxatives? What do you think? The answer is, if inadequate response after 4 to 6 weeks, consider osmotic laxatives. Encourage routine bowel habits, same time daily. This is very, very important. Now, coming to the case history number 2. 35 years old married lady. Chief complaints, recurrent constipation with abdominal bloating and discomfort. Stool frequency 1 to 2 times per week, occasionally with mucus. Past medical history, mild anxiety, no surgeries. Diet, irregular meals, low fiber intake, and high processed foods. She is using this. She reports bloating worsens with wheat bran supplements. On examination, vital signs normal, no palpable mass, DRE suggestive of hard stool in rectum. So the question on this case history, first question is, which type of fiber would be best suited for IBCC? Soluble, insoluble, or combination? Answer is soluble, low fermentable fiber to minimize bloating. Avoid high amounts of wheat bran as it may worsen symptoms. Second question: how can fiber be introduced to minimize bloating and discomfort? So the answer is start with 3 to 5 gram per day, gradually increase to 10 to 15 gram per day. The third question: would prebiotic or probiotics be useful adjuncts in this case? Answer is consider probiotics, that is the bifidobacterium lactulose for bloating relief. Question number 4 on this case history: how would you monitor her response to fiber therapy? Answer is track stool frequency, consistency, bloating, and abdominal discomfort. Adjust fiber types or dosage as needed. Question number 5, the last question. What lifestyle modifications could complement fiber treatment? Answer is regular meals, hydration, drinking water 1.5 to 2 liters per day, and moderate exercise. And stress management techniques, that is yoga, mindfulness if anxiety contributes. Now the case history number 3. 32 years old, 28 weeks pregnant lady, that is a third trimester. Chief complaints: difficulty passing stools for the last 3 weeks with bloating, straining, and feeling of incomplete evacuation. Stool frequency 2 to 3 times per week, hard and lumpy. Medical history: no history of gastrointestinal disease, surgery, or medications causing constipation. And diet is low in fruits, vegetables, and whole grains. She drinks 1 to 2 glasses of water daily. No red flake symptoms, that is the bleeding, severe abdominal pain, or weight loss. And on examination, vital signs normal, abdominal examination consistent with 28-week pregnancy, no palpable masses, DRE, hard stool in rectum. So the first question on this case history is, what are the main physiological reasons for constipation during pregnancy? So what do you think? What are the reasons that pregnant lady develops constipation? Answer is increased progesterone slows gastrointestinal motility, enlarging uterus compress intestines, and there is reduced physical activity, and dietary changes or inadequate fluid intake. All these leads to development of constipation during pregnancy. Question number 2 on case history number 3. How can dietary fiber help in this patient? Answer is the fiber aids bulk to stool, making it softer and easier to pass. The fiber increases colonic motility. And the fiber helps prevent straining, reducing risk of hemorrhoids. Question number 3. What are good sources of dietary fiber safe in pregnancy? Answer is fruits, apples, pears, and prunes. Vegetables like spinach, broccoli, and carrots. Whole grains, oats, brown rice, whole wheat bread. And legumes like lentils, beans, and chickpeas. These are the good sources of dietary fiber which are safe in pregnancy. Then the question number 4. What lifestyle modifications can support fiber intake? Drinking at least 8 to 10 glasses of water daily. Gentle physical activity, walking, prenatal yoga, and establishing regular bowel habits time after meals. The question number 5. When should we consider additional treatment beyond fiber? Answer is if constipation persists despite dietary and lifestyle measures, mild pregnancy, safe laxatives like bulk forming agents, isphol, or osmotic agents, lactulose under medical supervision. And always avoid stimulant laxatives unless recommended by obstetricians. Now, the case history number 4, 26 years old, 22 weeks pregnant lady. Chief complaints constipation for 4 weeks with bloating and mild abdominal discomfort. Stool frequency 1 to 2 times per week, hard and lumpy. The diet is vegetarian diet, mainly rice, roti, minimal fruits and vegetables. Drinks around a liter of water per day. No red flake symptoms. On examination, vital signs normal, abdomen soft, mild distension, DRE hard stools in rectum. So the first question on this case is number 4 is, what dietary factors are contributing to her constipation? Low fiber intake, inadequate fruits, vegetables, and low fluid intake. Question number 2. How can increasing fluids improve constipation? And the answer is, water helps fiber swell and soften stools, facilitating bowel movements. Question number 3. Suggest high fiber vegetarian foods safe in pregnancy. And the answer is lentils, beans, peas, oats, whole wheat bran, fruits like apples, pears, and prunes. Question number 4, on this case history number 4, what lifestyle modifications can help her? And the answer is daily walking, setting a regular bowel routine, and avoiding prolonged sitting. And the question number 5, when should an obstetrician consider adding a fiber supplement or laxatives? And the answer is if constipation persists despite dietary and lifestyle interventions. So, few words about the patient counseling and lifestyle integration. The healthy lifestyle tips is that eat food according to body needs, eat colorful vegetables, choose foods that are high in fiber, eat fresh fruits, eat highly nutritious side dishes, and drink at least 10 glasses a day. So the patient should gradual fiber increase. He should increase the fiber gradually. Hydration and physical activity must, and managing bloating and flatulence, and combining soluble and insoluble fibers. So all these are the points important for the counseling of these patients. What are the emerging therapies and adjuncts? It's the prebiotics, probiotics, and symbiotics. The probiotics, that is the live bacteria, and prebiotics, that is the food for bacteria. When we combine this, this is called synbiotic. It is a combination of both pro and prebiotics. Probiotics means live bacteria, prebiotics means food for this bacteria, and when these two are combined, this is called synbiotics. And the probiotics and prebiotics, they produce postbiotics, which is the uh, microorganisms and their components. Then there is emerging data about the fiber and osmotic laxatives, the osmotic laxatives, bulk forming laxatives, then the stimulant laxatives. All these are the different types of laxatives. And of course, the recent clinical trials are important. The recent clinical trials, they are about the novel pharmacological agents like linaclotide, the procalopride, which is available in Pakistan, then the plecanatide, and the ilobixibat, and of course the peripherally acting uh, opioid receptor antagonist, that is the Pemoras. And then there is clinical trials about the non-pharmacological interventions like vibrating capsules, fecal microbiota transplantation, and biofeedback mechanisms, and of course the dietary interventions. Key evidence gaps in the recent clinical trials are comparative effectiveness in long-term data. There's evidence gap, pediatric specific evidence is still a bit lacking, standardized protocols are still awaited, and of course subgroup identification is important, like mechanism of action. Studies on these is also very important, and patient reported outcomes and quality of life. Few quick clinical tips while managing patients with functional constipation. One is start low, go slow. It means gradually increase fibers to avoid bloating. Second is hydration is key. More than 1.5 to 2 liters per day. Then combine fiber types, soluble, which softens the stool, and insoluble, which aid bulk if tolerated. And of course, lifestyle matters, regular exercise and consistent bowel habits. And monitor and adjust. Reassess stool frequency, consistency, and tolerance. And this is the key of the success. Easy to remember mnemonics, and these are fiber for counseling points. When you counsel a patient of functional constipation, remember the mnemonic fiber. And what does it mean? F stands for fluid intake adequate. I means introduce gradually, introduce the fibers gradually. B, bulk with combination of fibers. You combine the soluble and insoluble fibers. E means encourage exercise, and R means review stool patterns. So when you counsel a patient with functional constipation, counsel them on the fluid intake, adequate fluid intake, and they should get the or increase the fibers gradually, and they should give the bulk to the stools with the combination of fibers. They should take the exercise, and you review stool patterns, tell them that they should review the stools patterns. Then for selecting fiber types, remember the mnemonic SOFT. And in the SOFT, S stands for soluble fibers, or the esophageal husk. Then observe tolerance, that as the patient observe the tolerates, the fiber dose should be increased. Then fruits and vegetables, preferred sources for the fibers. And of course, the tailored dose to patient. All patients do not tolerate the same dose, so you tailor the dose according to the patient. Remember, practical reminder for CIBS patients, prefer low fermentable soluble fibers to reduce bloating. So these are very important mnemonics, the fiber for counseling patient and soft for selecting fiber types. So summary tables of fiber types, the soluble and insoluble. The soluble fiber type, the properties are they dissolve in water, forms the gel and fermentable mostly. The key health benefits of soluble fiber is that soluble fiber helps lower bad LDL cholesterol and manage blood sugar levels and promotes satiety. And the primary food sources for the soluble fiber is oats, peas, the beans, apples, bananas, barley, carrots, and so on. The insoluble fibers, the properties that this fiber does not dissolve in water. It aids bulk to stool and it is less fermentable. The key health benefits is it promotes regular bowel movements, helps prevent constipation and hemorrhoids. And the primary food sources for the insoluble fiber is whole wheat flour, wheat bran, nuts, seeds, beans, potatoes, cauliflower, and green beans. These are the different references on the basis of which I have made this presentation. When you get the chance, please go through these. The 2011, then the 2020 and 2018 and 2019, the recent trial, the studies, I have taken the help of these articles to make this presentation. So the key take-home messages from today's discussions are: fiber is first-line therapy for functional constipation. Individualize types, dose, and combination of fibers according to the patient. Patient counseling is critical. Monitor tolerance and adjust interventions. So thank you very much for being with me in today's session. I hope I was able to give an overview of the functional constipation. What does it mean? What are its causes? What are its clinical features? How we diagnose? What are the types of fibers? What's the role of fibers in functional constipation? What are the different mechanisms with the help of which the fibers they help constipation? And then we went through 4 case histories as the everyday clinical practice, and we learned how we apply or how we use the fibers for functional constipation in our everyday clinical practice. And then we just discussed the future, the upcoming drugs for the functional constipation, and then we learned few mnemonics to remember while we treat with patients of functional constipation in everyday clinical practice. In the comment sections, please do share your thoughts, your experiences, your approaches of treating functional constipation patients, so our discussion goes on and we learn from one another. Thank you very much. See you in the next vlog on some another topic. Till then, take care. Khuda Hafiz.